everyone present here in the Council Chamber and those who are listening online. Before we begin, for those of us in the Council Chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council Chamber through the rear doors, through reception and assemble in the car park at the front of the building and await further instructions. I would also like to ask for all mobile phones to be switched off or placed on silent, please. I'd now like to move into agenda item 1, apologies for absence and replacement members, please.
Thank you, Chairman. We've received apologies from Councillor Ray Wotton, Councillor Sandra Harrison, Councillor Lucille Higgs, Councillor Glynis Scalesi, and today we have Councillor Boston as replacement for Councillor Scalesi, and we also have 2 new members. Councillor Haig, sorry. And we also have 2 new members, Chairman. We have Katie Chalmers in place of Stephen Woodliff, and we also have Jane Loughagan in replace of Bill Bilton.
Thank you, Trina. I also believe we've got Councillor Colin Matthews that is tapping in via Teams. So welcome to the meeting, Colin, who is the Executive Support Councillor for NHS Liaison, Community Engagement, Registration in the Coroner's Service. And I would also like to welcome from the Chair, Councillor Loughagan, Councillor Chalmers and Terry as well. Welcome back to the meeting, so thank you.
Thank you, Carl.
We'll now move into agenda item 2, declarations of members' interest. Do anyone have any interest they wish to declare at this point? No? Okay, thank you. In which case, we'll move straight into agenda item 3, the minutes from the 13th of April 2022. These can be found on pages 3 to 16 of the agenda pack. And as the committee have had the opportunity to read these in advance of the meeting, I plan on taking these en bloc. Do I have a proposer for these, please? Thank you, Councillor Linda Wootton. And do I have a seconder, please? Thank you, Councillor White. All those in favour, please show. Thank you. Any abstentions? Thank you. 2. That's it. Thank you. Okay, in which case I can confirm the minutes are accepted. We'll move on to agenda item 4, the Chairman's announcements. My announcements have been circulated with the agenda on pages 17 to 25, and my supplementary announcements were emailed on the 17th of May. Are there any questions on these at all, please? Councillor Smith.
Thank you, Chairman. Regarding the additional funding made available for additional dental appointments, could this, and I'm being partially presumptuous, but could this be an issue of contractual arrangements, much like the discussion we had last month around the GP contract and issues around that? It's deeply concerning that so few additional sessions were taken up in Lincolnshire, especially when you consider how long-standing the issue of dental access has been prevalent in Lincolnshire long before any pandemics, before the pandemic and any other issues taking place. As we all know, the pandemic's merely exacerbated this already long-standing issue for residents. And I wish to record my concerns on the record, Chairman, that so few additions were taken up.
Thank you, Councillor Smith. As I'm sure you'll be aware, on next month's meeting we have got a presentation on this exact item. I have got a pre-meeting to go over what it is that we're expecting from our presenters on that one, so I will ensure that I raise that with them directly and have something within the paper for next month. Thank you, Councillor Smith. Councillor Whittington.
Yes, thank you, Mr. Chairman. Just 2 brief comments. The first on number 4 on your Chairman's announcements, the opening of the Grantham Community Diagnostic Centre. As a Grantham councillor, I really welcome that. A tremendous addition to level of services provided to residents in Grantham. And my second point, it relates to item 6 regarding the Stackyard surgery, which is the surgery, as you recall, that's in Ulht by Beaver, which is in, it's not in my district seat, but it's in my county seat. It was transferred over from Lincolnshire CCG to the Leicestershire and Rutland CCG. The surgery is now a pile of rubble because it's been pulled down. It's right next to the social club in Wolfthorpe, and I was there for the parish council meeting on Monday, and it reported to me that at the time of the transfer, the East Leicestershire and Rutland CCG and the practice in Crowson that was taking it over did promise and commit to ensuring that regular pharmacy deliveries would be made to the residents of Wolfthorpe by Beaver. This has stopped. They only did it literally for the matter of a month or so, it stopped. So now residents in Walsall by Beaver don't even get their weekly prescriptions delivered to them. So I just wanted to obviously it's now sort of outside of our remit because it's gone to East Leicestershire and Rutland. But these were issues and concerns that were raised at the time by residents of Walsall. This was their fear, and unfortunately this is what's actually happened. Thanks, Mr. Chairman.
Thank you, Councillor Whittington. We'll pick that up with the Clinical Commissioning Group for Lincolnshire. They obviously will have some contractual arrangements that should have been put in place, as you've rightly said, and so we will speak to our counterparts there. So, thank you, Councillor Whittington. Councillor Allen.
I'll take it now. Thank you, Chairman. It's item 4 and 5. Whilst the CDC in Grantham is very welcome, there is consultation taking place on the second one. Do you know whether the second means the next and the last one for Lincolnshire, or is there more planned? Bearing in mind there's only 40 for the country as a whole, I doubt the answer is that it is more than the last one.
Thank you, Councillor Allen. I'll hand Simon.
Well, thank you, Chairman. Maybe that is a question for next time. I'm not sure whether any of the NHS colleagues in the room are able to respond to that. I know that there is a consultation ongoing about the second one, which the committee will be looking at on the 15th of June. But whether there will be more for Lincolnshire is I don't know if any colleagues can help.
There's one more, Councillor Allen. I've just got Simon Evans that's coming in, please.
Oh.
Thank you.
You might be able to answer.
Sorry for the confusion there, too many Simon Evans. Yes, so we do intend on delivering more CDCs. This is the second one. We are looking at, obviously, in terms of consultation, where they're best placed, but it is part of the strategy. And I'll perhaps touch a little bit on it in the slides, although I think we're hoping to bring back a more comprehensive CDC review next time.
Chairman, if I could just say why I've raised the question. The consultation would naturally, I think, focus on different issues if there are more planned. That's why I've raised it.
Perhaps if I touch on it a little bit more in my slides, if I could go into that a little bit more, I think in reality going into this in much more detail would be better next time, if that's okay.
I agree, that's why I've raised it.
Yeah, thank you. Well, we can pick that up anyway. So we've got the work programme and we can talk more extensively in there about that particular item. And I think we've already been told it will be touched upon. So thank you. Any further questions? No, thank you. In which case, do I have a proposer that we take my announcements as noted, please? Thank you, Councillor Smith. Seconded, Councillor Wootton. All those in favour, please show. Thank you. That's supported. In which case, I'll move on to meeting conduct. Before we move into the substantive part of the meeting, I would like to ask that you keep your questions and contributions succinct and concise, and ideally no more than 2 questions per person per item. I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'd now like to move into agenda item 5, United Lincolnshire Hospitals NHS Trust, Recovery Plan and Response to the CQC. This item has been circulated in pages 27 to 144 of the pack, and I'd now like to welcome our presenters, Karen Dunderdale, Director of Nursing, and Simon Evans, Chief Operating Officer. I've also got Sarah Blinkworth for the STP Planned Programme Lead, so welcome, and I'll hand over to you for about 10 to 15 minutes presentation, if that's okay. Thank you.
Thank you, Councillor Macy. So I'll start, colleagues, if I may, and update you in terms of the CQC, and then Simon will take over and offer you an update on the recovery plans for the Trust. So colleagues will remember through the medium of Teams, I joined you at the end of March when the CQC report had been published for United Lincolnshire Hospitals Trust, and we said that we would come back and offer you the detailed improvement plan which you have in your pack. Starts at page 28 and the actual detailed action plan on page 47 onwards. These papers that you have are in 3 parts. So you have a public board paper from the Trust's meeting in April on the progress with the improvement plan following the published CQC action plan report, from February, which we then submitted subsequently on the 10th of March to the CQC, and they've duly accepted, along with a slide deck giving you a summary, in particular the first slide, which gives you some details of timescales and timelines, and then appended to that from page 47, the detail of the improvement plan. At the same time as us pulling this together, you'll also notice in the pack that there's detail of the assurance arrangements that we've put in place, led by myself as one of the board clinical leads as the Director of Nursing, along with my fellow medical director, so that we can assure ourselves that we do remain on track, and should we see any slippage from our improvement plan, that there's clear mitigations and clear plans to recover any of that over time. So those oversight arrangements are in place, along with monthly reporting to the board subcommittees and then quarterly oversight reporting to the board itself, all of which is now in place. So for ease, in Appendix 1, you will see a summary of the required CQC recommendations, which comprise, in comparison to 2019 CQC report, you will see there's a significant reduction in both the must requirements and the should do requirements from the CQC. And indeed, the Chief Exec and I discussed some of those when we met with you a few months ago. So these are significantly reduced, especially the must do actions. I'd like to point out that although an action may be related to one site, we are ensuring and checking that we're covering each individual recommendation across all of our sites, and indeed where applicable across all of our divisions. An example of that would be a specific recommendation around the ambient room temperature and storing of medications in the maternity service. We're looking at all of that to seek assurance across the whole of the organisation. And then from page 47, as I've already said, offers you the detailed action plan. I just want to reiterate to Chamber and to this Overview and Scrutiny Committee that none of the recommendations that the CQC offered us were a surprise. We now have a track record, I think, because of the widespread significant improvements that were seen by the CQC in their visit to us recently, that we are in a position where we are improving and we will be able to deliver this action plan. I'll pause at that point, Councillor Macy, and I'm more than happy to take any specific questions. Thank you.
Thank you. You're fine to continue on, because I think it's always easier if we take questions at the end so it doesn't get muddled somewhat between any questions from our committee.
Okay, thank you, Councillor Macy. So I'll hand over to Simon Evans to take you through the recovery plan. Thank you.
Thank you for that. So we've put in the pack a series of slides, which, if you don't mind, I'll take as a read, and I'll talk through the salient points, if that's okay, Chair. So what you have in front of you there essentially sets out the system, the Lincolnshire system recovery plan, and you will hear more from us in a way of describing what the system effort is, as opposed to necessarily just things that are specific to ULHT. I'll try and draw out the difference between the two, so that's obvious, but that's fine, thank you. So if we move on to the first slide, if we could. So what we'll articulate in some of the numbers and the things that I'll explain today is where there are some of those differences between what's ULHT and what's system. My colleague Sarah here is with me today, and actually that is the way that we operate now. Very much the Lincoln Hospitals works anonymously now with our system colleagues, and as part of that is making sure that we are paying very close attention to other providers that care for our patients across Lincolnshire, such as North Lincolnshire and Goole, North West Anglia Foundation Trust and Nottinghamshire Trusts that surround us, who actually treat a sizable proportion of our patients. The reason we're doing that, obviously, is because we do have some opportunities within Lincolnshire to offer shorter waiting times and a way of tackling some of the burden of the coming out of COVID in terms of large waiting lists. And we are now actively doing that, working with colleagues out on the boundaries in those other trusts to make sure that we can offer the best waiting times for patients going forward. This is common with systems across the region and nationally, and this is the way that we're operating here in Lincolnshire. Within these slides, it describes ultimately our ambition, and part of the national guidance is ultimately to deliver more elective activity than we have done over the last 2 years, and actually not only to return to pre-COVID levels, but to deliver over and above the level of access and treatments and outpatients and activity to patients than we've ever done before. If we could skip on to the next slide, please. How will we do that? COVID is very much still a part of how we have to deliver services in Lincolnshire. And although it's lovely to be back here with you face to face for the first time, I think now in 3 years, in our hospitals, we still have to be extremely careful around COVID, even with vaccinations and the level of progress we've made in tackling it. Particular examples of that are around people that require anaesthetic for their procedures, who have to go under general anaesthetics. It is still a sizable risk factor and impact on mortality for those patients. So therefore, we still have to make significant provision in making sure that we're reducing the amount of COVID transmission in our hospitals, but also making sure that we are fully aware of the status of patients coming through. And because of that, it does pose a substantial challenge to us, not just in terms of how we manage patients coming into our services, but also when people are in our hospitals, the environmental factors and our workforce factors that need to make sure that we protect people when they are in our hospitals and working with our health professionals. Another key element of that is our own workforce challenges, and of course we need to make sure that we, where possible, can reduce the nosocomial transmission. That's where we may have patient-to-patient or staff-to-patient transmission of COVID within our hospitals, making sure that we manage that risk accordingly. And that does mean we have still an increased level of sickness and people who can't work in our hospitals face-to-face with patients because we're having to isolate because of COVID. We still very much do the testing regime that's been in place since COVID began. Our ambitions incorporate not just increases in productivity and the way that we run our services, but we also have an intention on a relatively small amount increase in headcount and in our overall workforce. And although 531 seems like a huge number in terms of extra people compared to the circa 20,000 people that are working in elective care across Lincolnshire, it is relatively small here, but an important one, and in some specialties particularly important as we try to recover waiting lists that have stretched in some cases to more than 2 years. If we could move on to the next slide, please. So what you can see here is in terms of our ambitions, both the system and the ULHT ambitions of where we expect to be delivering the levels of activity and the numbers of patients going through. And as you can see, most of our ambitions on elective recovery revolve around a circa 104% of what was being delivered 2019 and 20, so pre-COVID levels. Some of that is delivered, that extra is delivered through ULHT ambitions, in some cases stretching up to 107, 108%. Some of that is also going to be delivered in combination with our independent sector colleagues as well, and other organisations as part of that. You'll note that some of these areas and the way that we're delivering services are going to build on some of the really positive moves that we made during COVID of consultations that are not delivered face-to-face, so remote consultations, digital, and providing access, better access to patients probably than they had pre-2019 and 20. So if we just move to the last slide, if we could. In terms of physically delivering this, we touched a little bit on CDC. We have actually managed to put in place additional physical treatment environments and reconfigured internally within our hospitals a substantial amount. In fact, last year at ULHT alone, not including the other trusts, we delivered more than £45 million worth of developments within the hospitals to try and increase the amount of patients that we could see, particularly as we go into our recovery. And that's not unique to ULHT. We know that our colleagues in Nottinghamshire, North West Anglia and North Links and Gould have all done similar sort of schemes. CDCs are a key part of that, and really pleased that we've managed to get the Grantham CDC, which is building on some of the work that we did during COVID, up and running. Colleague Karen opened that with councillor colleagues recently, and it will be part of a number of CDCs. We do have to go through a cycle of business case bidding, design, consultation for each of these CDCs as we go forward, but our expectation is that that wouldn't be limited to 2, and that will expand over time. And that helps us also with managing health inequalities across Lincolnshire, where access is a particular concern, but it also helps us deliver more than 120% of our diagnostic capacity from pre-COVID, which is required to make sure that we can manage things like our cancer pathways effectively. Now, you'll all know that unfortunately we did have a fire at Lincoln hospitals, and that is a real challenge to us, particularly in our diagnostic imaging services, and we've had to put in place many temporary measures to be able to manage that, but we're still very much confident that we'll achieve the plans that are set out in this report. And then finally, just a sort of latest position in terms of our weights. In Lincolnshire, we are actually in quite a strong position, comparably with the rest of the Midlands and nationally, with our most extreme delays. So 2-year waits, 104-week waits are typically the standard that the NHS is trying to tackle and to reduce and eliminate completely, and we are very well placed in Lincolnshire to have those completely eliminated by the end of June. And in fact, we're down to only 17 patients now waiting for ULHT. We're also, in terms of our ambition, expecting that we will have eliminated all of patients waiting more than 78 weeks by March 2023, which is, whilst still seems an excessive length of time and something that we want to really tackle, regionally and nationally, that is an ambitious target to achieve, but we're confident we'll be able to do that. So I hope that's useful in terms of adding a bit more of a focus onto some of those slides. Happy to answer questions.
Thank you very much. Yeah, we've got questions already. I've got Councillor Whittington first, please.
Thank you, Mr. Chairman. Thanks, Simon, and thanks, Karen, for the presentation. It is good to see people back face to face. I've got a couple of questions, both related to the final slide you showed, where it lists out all of the key risks. And for me, two spring to mind. The first one around the workforce, and obviously you got plans to increase the number of whole-time equivalents, and at the same time as having less reliance upon agency staff. And I'm guessing from your perspective that's good because financially it's better than having agency staff, and also I guess that it makes the workforce a lot more stable as well. But obviously, historically we know in Lincolnshire we've had problems in recruiting staff and key staff. So I'm just wondering if you just get a bit more explanation around that and what measures you'd be taking to try and attract the staff, because it is admirable that you are trying to increase the workforce and have a greater reliance upon your own staff as opposed to agency. But just some ideas about where you're plans you've got in place to attract them. And the second one, I've kind of mentioned that around the financial risk, because obviously potentially this is going to cost money. And I'm just wondering if it's going to be funded by extra money coming in from government or from another source, or whether it's got to be generated internally by making savings elsewhere. Thanks, Mr. Chairman.
Thanks very much for that question, Councillor. So, I'm pleased to say the workforce, we actually have some good examples of where this has already started. And it's really following on from Karen's presentation, is that it is a substantial step forward for us at ULHT to have stepped out of special measures, to have left behind some of the stigma of the CQC issues that we've had, and we have already seen recruitment processes now with more candidates applying, with people with great credentials, people who are willing to, in some cases, specialists willing to move to Lincolnshire to work with us, and the reputation of the organisation has really lifted, particularly over the course of the last year or so. And that's really important for very specialist roles, because they're the ones that have been really catching us out, and they're within that 530. They're relatively small numbers, but very, very important for us. And colleagues such as Mr. Simpson behind myself, we need to make sure that there are more of those specialists to help us in this recovery effort. So that's a bit of good news so far, and of course we're going to make the most out of that. So in terms of our marketing of Lincolnshire and ULHT and the Lincolnshire system, we're going to absolutely build on all of the positive news that's come out of that, moving out of special measures, but also some of the positives around how far we've managed to reduce our waiting list already, which is amongst the best in the Midlands. So from a patient experience, whilst absolutely recognising 2 years is a phenomenal length of time, comparably across the country, the position that we have in Lincolnshire is much better. And again, that will attract more of our clinical colleagues to come and work with us in Lincolnshire.
If I might add to that, Councillor Whittington, Councillor Macy, of course you know that we're undertaking a lot of work looking at university hospital teaching status as well, and that can only increase the reputation of the organisation. And as Simon said, some of our key clinical consultant posts that we've recently recruited to have come because they want to be involved in that. What that's also meaning is we're doing some specific work with the University of Lincoln on rotational posts, fellows, not just for our doctor workforce, but also for our allied health professionals and nursing and midwifery workforce. In addition, we're looking at new and emerging roles, so trying to stretch the boundaries of the professions, which all of the Royal Colleges are very keen to promote, and we want to be part of that. And we've just seen the recruitment of 220 this last month, healthcare support workers into the organisation, some new to the caring profession, others that have worked in the caring sector but want to move into an acute trust. So of course it's beholden upon us then. What's really important is the retention element of our strategy. So these are fantastic individuals that we want to keep, and one day, who knows, one of them might be sat in the seat that I currently occupy. Thank you.
Councillor Whittington, just microphone.
And just the reassurance on the finance and how it's going to be financed. Thanks.
Sorry. Yes, the way that the national funding mechanism is set up for this year, very different to previous years during COVID, but it does reinforce funding will follow essentially where you are sizably reducing your waiting lists and delivering more and more. So as we look to operate on patients over and above the threshold from 2019 and 20, additional money will come into the system to follow that. But there is absolutely an expectation that we are productive and efficient in what we do. And we know that COVID has created us new challenges in being less productive because of space, because of the measures that we've had to take. And we need to work on those to make sure they're as efficient as they possibly can. We've got a really good track record in doing that in a scheme called Getting It Right First Time, which is a national initiative. And we're making real progress on that as well. So both those things will help us balance the books for this year.
Thank you. Just building on from what Councillor Whittington said, you've sort of alluded to some of the recruitment and retention, but what are your current gaps at the moment, especially in the areas that the CQC have highlighted?
So if I pick up first, Councillor Macy, thank you. So the key areas that the CQC visited us were urgent emergency care, children and young people, maternity and medicine. Across children and young people, we have very few nursing vacancies. We've just last week appointed 2 fabulous paediatricians who will be joining us, and that will leave us in a really good position for paediatrics. Maternity, we're in the process of recruiting on the back of funding related to the Ockenden review. There was a sizable amount of national funding, again to support us with obstetricians and additional midwives. We're very lucky in Lincolnshire that our student midwives want to work in our maternity services, so that gives us that pipeline of midwives. So again, in a really good position. In terms of urgent and emergency care, we do have significant gaps, both in terms of nursing and across our medical professions. And that, as Councillor Whittington alluded to, is where we have the majority of our bank and agency usage. So again, some very proactive plans. The board has just supported £1.5 million worth of additional nurse funding into our emergency department establishments. Arguably, we're already using that because we have long line block booked agency support. So the gaps are filled by temporary workforce, but we've got to reverse that position so that we're moving into a substantive workforce for the points that you made, Councillor Whittington. Thank you.
Thank you. Councillor Allen.
Thank you, Chairman. It's good to see so many reports and so much work that's been done on the CQC side of things. That response is obviously important because it feeds into the rest of your delivery. My interest to a certain extent is more to do with dealing with the backlog caused by COVID, certainly in elective care. We have a report that sets the scene, I think, to a certain extent in terms of what's likely to be happening. The concerns I've got is that I don't see how we can deal with the 6.4 million patient backlog without really innovative thinking, because it was growing before the pandemic, and I think waiting lists may well continue to grow as more people come out of the woodwork and go to hospital to see to the pain that they've had for the past 2 years. And it's good to see that the diagnostic element of the service you provide is going up by 20%, although that might simply increase waiting lists and the need for elective care. If I'm reading your table right, the increase in the elective care is going to be 4% over pre-COVID numbers. I do wonder what that is actually going to amount to in relation to reducing waiting lists. It does not seem as though that has got a great deal of innovative response to a significant number of millions of people waiting for care, in my view. You may be able to give me some comfort that that's the case, or you may be able to give me some comfort that that's just a starting point. Chairman, I would like more information about what the, because this to a certain extent is marked as priorities, and more information that sort of gives meat to the plan that is going to be operated over the next few years in terms of dealing with the backlog. For instance, the number of, how many of those 6.4 million waiting list patients are in Lincolnshire, and how does 104% start decreasing that? Or does the 120% increase in diagnostics and people coming out of the woodwork increase it over the next few years? The percentages are all very good, but I think we need more meat to actually show that there is a plan here that's going to actually reduce the amount of people that are waiting for elective procedures of one form or another, and that number is actually reducing over the periods of time. And the reason why I'm raising it is it all seems to me to depend on the number of first-line clinical staff that you've actually got, and increasing the amount of space that you've got in theatres and wards to actually put that through, and indeed dealing with some of the risks that you've got associated that Councillor Whittington's already raised, a number of the risks that you've got that have been identified actually being resolved. And I don't see that as part of a plan that that knowingly shows us how this is going to be addressed.
Thank you for that question. There's quite a lot to it. absolutely note that there's a huge amount of work that sits underneath this in terms of that level of detail. What we'll try to do, given this is sort of our first step into this with the council colleagues, is to keep it at that level so that we can understand what our ambition is, what those high-level plans are looking like. But if I perhaps touch on some of the detail underneath it as some examples, and then perhaps going forward we can bring additional elements of this through to future meetings. We will have more theatres. So we have additional theatres, physical theatres being delivered. In fact, at Grantham at the moment, some being constructed. We will have more scanners, CT scanners, MRI scanners and X-ray machines, ultrasound machines than we will ever had before. And that is across all of Lincolnshire, including places like Ulht and not just in the main acutes. We've described how we will also have more staff in terms of additional people to do that. Absolutely noting the challenges that I've described there, the risks of inefficiencies that are in there. But also we have got a sizable amount of innovation that we've developed over the course of the last 2 years. Part of that is the step into sort of remote consultations and contacts with patients, which would normally require people trekking across Lincolnshire to have a face-to-face, which is hugely time-consuming for patients, but also substantially time-consuming for us in terms of managing that whole process. And at our peak during COVID, nearly 50% of all consultations in outpatients were being delivered remotely. Some of those were to maintain safety, so they weren't necessarily to further treatment, but to make sure patients were safe whilst they were waiting. But actually a sizable amount of that has led to us being able to manage things in the community, or not having to bring people back into the hospital, and actually reduce the amount of time required by our clinical colleagues. And Mr. Simpson behind me is key in that, in terms of developing those services, and also with primary care, because we also note that our GP colleagues have the same, if not more, contact with some of our patients on our waiting lists, and actually together we can make smarter decisions about how to manage their care going forward, particularly those that are on chronic care pathways. In addition to that, we've also got a new equipment, which means that we've been able to change some of the procedures, and robotic surgery is a development that we've put in place over the last year. Some of those patients would typically have waited for a further year to go out to a specialist centre outside of Lincoln. Now we're able to operate on those patients within Lincolnshire itself, bring those people back. And this is just the beginning. The Getting It Right First Time programme national initiative is exactly that, is about making sure that we deliver the right treatment for the patient at the right period of time. It sounds obvious, but in reality it's actually very tricky to be able to do that and align all the things that we need to in many of these pathways. And as part of that is a scheme we're looking at, which is called high volume and low complexity, which is those patients that have been waiting for something typically for quite a long time because of its low acuity and the impact on patients, but nevertheless we do need to operate at some point, and we collate multiple patients onto lists where we can actually have a much more productive list, and some of the productivity gains there are up to 100% in terms of the number of patients we can treat at any one time. And of course we do have what many systems don't have, in that we have access to somewhere like Grantham Hospital, which does have a greater degree of access to elective care that is more protected from the acute pressures on the likes of Lincoln and Boston. Again, helps us as a system be able to manage reducing the number of cancellations as part of urgent care demands. So appreciate that's just a thin slice of a few things that are going off underneath this, and happy to bring additional information back in future, Chair.
Chairman, thank you. There's a lot happening, that's very good. But I still go back to the figures that you're talking about, in terms of 4% improvement in terms of overall output. I do think we could do with some more, detailed information about how this is going to impact on the waiting list in Lincolnshire over the next years, because it would be pointless going through all this, doing all these sorts of things and investing all this time and effort in resources and provision if that is not happening. Because you know, this is what it's all about. It's a recovery plan, not simply moving forward, you know, for the next decade or whatever.
Might respond. Excuse me. Yeah, thank you. That's it. Thank you. Just get the button right. If I might respond, Councillor Allen, absolutely right. And of course, this is a national priority, the waiting list, and the shape of the waiting list over the 2 years of the pandemic has changed significantly. Whereas before we'd describe it as a small number of patients waiting a long period of time, and you'd see the effect of a bulk at the beginning of the waiting list and then a small tail where you'd got numbers. That has significantly shifted, where you're seeing that bulk of patients further along. So it's a clear national priority. It's clearly one of our priorities, not least of all in terms of quality and patient safety and the experience of our patients. And of course, as you might expect, we're working through a number now of trajectories so that we can be really clear about where we will be over set periods of time, because there's a very clear national ask of all acute trusts in terms of the waiting list position, both in terms of patients new to the waiting list and those that are requiring follow-up as part of the waiting list, let alone the diagnostic waiting list position, which we've had a number of conversations on already. So we're more than happy at any future overview and scrutiny meetings to bring our high-level trajectories, which the board itself will sign off. Thank you.
Thank you. I've got Mr Simpson that wants to come in as well.
Thank you, Chairman. Just to expand on that, speaking as a surgeon, we were very much challenged by Professor Briggs from the Get It Right First Time team to meet the huge challenge of addressing the waiting lists. And there were detailed figures supporting how we can do that by looking at, as Simon said, the utilisation of theatres, additional theatre capacity, 7-day working and improved techniques. And it might be helpful to share those figures with the group.
Thank you. And we will be asking for an update in 6 months' time anyway, so I think that's the sort of time we'll bring that back, and I think that'll be useful. Okay, thank you. I've now got Councillor Parkin, please.
Thank you, Chairman. Interested in terms of recruitment, but this time of non-medical staff. I was reading yesterday that we have a national shortage of graduates, and for the first time ever, we actually have more vacancies than we have unemployed people nationally. So I was just wondering what that recruitment crisis potentially is looking like for you guys, and how that may impact on delivering those outcomes, because obviously I should think you have got as many non-medical staff who you are reliant on as medical staff, and I think it's important as a committee we recognise that that could pose a real risk to you guys moving forward.
Thank you. If I might respond, Councillor
Karen,
Parkin.
Simon, you've got your microphone on. Would you mind switching it off, because it will cut out others? Thank you. That's right.
Thank you, Councillor Macy. Thank you, Councillor Parkin. So I think I've already alluded to some of the non-medical workforce, and you're absolutely right, but before the pandemic there was a 55,000 vacant registered nursing position. That's only grown throughout the pandemic. We do see sizable gaps nationally across the NHS for the non-medical workforce. As I've already said, we've been doing quite a lot of work with the national team about recruiting in healthcare support workers, which are the non-registered workforce. The University of Lincoln have taken on a significant increase in student nurse placements from this year. And of course, the impact for us is supporting their clinical training placements, which we've expanded to enable that to happen. Now, of course, for registered nurses, that impact comes to us in 3 years' time. So it's really important that we start to think about new and emerging roles, the apprentice route, which we're real advocates for, how we can think about nursing associates now, which are equally registrants and can take on additional responsibilities over and above your unregistered workforce, but don't go through a 3-year programme in the same way that a state-registered nurse would. And then thinking about our allied health professionals as well. and then overlaying what the demographic of the current population looks like. Most of the population of the current workforce are in that age bracket where in the next 5 years could retire if they chose to do so. Particularly if you're in the 1995 pension scheme where you get special status and can retire and take a full pension at 55, and you see most professionals choosing to do that, which certainly wasn't the case 3 decades ago when I joined the NHS. Colleagues worked until state pension age. So taking all of that into account, we're really clear what that looks like for us. We're clear what that looks like in terms of whole-time equivalent across both nursing, midwifery and all of the allied health professional workforce. It's a sizable number. And so we're working through what are the various entry points into our trust so that then we can offer a career escalator. So again, anybody could go from apprenticeship route right through to the Director of Nursing if they chose to do so. And we've already got that in place and we're working through that. So again, if it would help the overview and scrutiny panel, at some point we could come back and we could walk you through some of that high level information, where we started, where we are and where we intend to be.
You may come back.
That's really, really good, Karen. I can appreciate that. But what about the backup teams behind this? Your admin support, your business support, HR, all the rest of it? Because if we've got, I am hazarding a guess here that if everybody else is finding recruitment issues in those areas, then you guys are as well. And so it's good to hear about those kind of that support for the medical side of it. But what about the entirely non-clinical staff that are really crucial for us moving forward?
Thanks for that. So we haven't seen a material change, in fairness, and I think you could argue there's some negative elements of COVID would have put some people off, but in some cases actually has encouraged people to join, particularly acute trusts, in terms of those support roles. I think we may see more of that over the course of the next few years, and the same strategies that Karen's described for sort of going through to the clinical route would apply to managerial, to estates, to tradespeople, all of those other roles. We have a widespread apprenticeship scheme, which we look to leverage as much as we can. So whilst absolutely recognising is a risk, and it's a risk that's going to grow probably over the next couple of years, I don't want to sound too confident, but it hasn't been as big a hit for us as it may have been for other organisations. What we may have seen is that outside in the community and care providers and other services outside the acutes, we may have started to see more of an impact in that, but I would struggle to be able to speak confidently about all those organisations.
Okay, thank you, and we'll pick up some of what's been said as well in the work programme later on. So I've got Councillor Boston next, please.
Thank you, Chairman. I've got two very simple questions and one that might cause a little bit more concern. The two simple questions are, firstly, and do excuse me, I may be a little bit out of date with what's been happening over the last few months. It's very good to hear that we've got more paediatricians joining us. Does that mean that we're now going to have Boston opened up again as a properly functioning paediatric unit? To a lot of people in my area of the county, and certainly a little bit further south, it is important. They seem to have lost or again, I say I might be a little bit out of touch, but that paediatric unit was very important to them. So I would like to know that. Secondly, slightly more problematic, I've been involved with this scrutiny committee for in excess of 8 years, probably nearer 10. And one of the first things I saw when I came onto this committee, and it has been repeated every single year since I've been here, is the problems with ambulance delays. And every year and every time we've spoken about it, there have been plans afoot to do something about it. We're still there. We've still got these ambulance delays, and we're saying that it's important. When And please give us a proper timescale. When are we actually going to do something about it, instead of create a new plan or repeat the old plan and get something done? Because it's not just the impact of people sitting in ambulances, it's the impact of getting an ambulance out to somebody because they don't have an ambulance available. Just one example, I don't intend to use it as I'm not going to name people. A lady in her 70s collapses in her garden. She's significantly overweight. The temperature is below 0. She apparently has a broken leg, can't get up. 999 call says the ambulance is going to be a minimum of 6 hours getting to you. 6 hours for somebody who is in a potentially life-threatening state, hypothermic, injury potential, and it's caused because we've got a waiting list that hasn't been addressed properly for in excess of 10 years. I need something doing about that. I need some answers. We needed answers 10 years ago. Nobody is prepared to do anything and give us some direct answers. And finally, the other question goes on to your training, your plan for doing something about things. I see that you have on the plan elements that require mandatory training, which are must-dos. I've also heard an awful lot over the past half hour about people needing to be brought into the service. What happens to those people who fail to engage properly with the mandatory training? If it's mandatory, it's important. What are we going to do about those people who don't engage? Has this even been considered with the unions? And are the unions in support of us? Because I raise this because the mandatory requirement for COVID vaccinations was attacked by the unions and eventually dropped. Are we going to drop this mandatory training again? Thank you, Chairman.
Thank you, Councillor Boston. So I'll start with the last and we'll work backwards if that's all right. So in terms of mandatory training, it's exactly that. It's mandated, so it must be undertaken. Now, for all staff groups, particularly the clinicians, if I start with our widespread clinicians, in order to revalidate, to keep your professional registration, part of that, you must be able to demonstrate you've undertaken your mandatory training. For all other staff, as part of their appraisal, you have to be able to demonstrate you've undertaken your mandatory training, particularly if you're due your next financial increment rise. So we can, through the Agenda for Change route, prevent increment rises if you've not completed a number of things, of which mandatory training is one of them. So that's always an incentive. There are times, however, where colleagues may be due to renew their mandatory training. Fire training may be an example of that. Manual handling may be an example of that. But you weren't able to do it at the time that you were booked, either because you were required to support the shift, you might have been off sick, there might be a whole raft of reasons, and we would then ensure we give people a grace period to be able to undertake that training. So in terms of staff side, absolutely support that, because it's well recognised across all of the unions and all of the professional royal colleges that in order to ensure that the workforce is highly skilled, at a very minimum you must undertake your mandatory training. And in order to ensure that we've got a level of due diligence of the workforce, we must be able to demonstrate that colleagues have undertaken their training. So staff side, absolutely supportive of that. I can't think in probably my entire career and all of the organisations that I've worked in that I've ever had to go through a HR process for somebody who won't and intentionally will not engage in the mandatory training process. But if we ever found ourselves in that position, then there'd be a clear mandatory train. It's a breach of contract. It's clearly written that colleagues must be trained. So I'll hand over to Simon to pick up your other 2 points around ambulance delays and the paediatric at Boston.
Thanks for that. So, recognising I'm probably talking about other areas other than planned care today, of which some of my colleagues are probably better placed to be able to respond, but I'll very much try my best to answer the questions if that's all right. So, ambulance handover delays, rightly, were an issue for us pre-COVID. I absolutely get that. Indeed, urgent care was a challenge for Lincolnshire system per se. Ambulance handover delays and ambulance delays are actually a symptom of a wider spread issue around urgent care and emergency care, of which we also see things like prolonged delays in A&Es as another indicator of it not working. The comparative between pre-COVID and current levels, both within Lincolnshire and nationally, is a very difficult one now. We are multiple factors worse now than we've ever been, and possibly worse now than we have ever been in the history of the NHS nationally. And obviously I'm just replaying things that have come out in national and regional news, but that is a genuine challenge for us in terms of within the NHS per se. Lincolnshire is obviously, our rurality contributes to that because of the geography and the challenges for East Midlands Ambulance Service in being able to respond to patients. And indeed, one of the key factors that's driven that is the number of is the level of occupancy of our hospitals in emergency and urgent care. And indeed, this morning, 175 patients within Lincoln and Pilgrim hospitals didn't need acute care, didn't need to be in hospitals. At the same time, 55 patients were waiting for beds who were in A&E, who had been there for prolonged periods of time, who were occupying a space where an ambulance should be handing over. So if you think of that sort of flow back in the system as what we talk about, because we're at such high levels of occupancy, it means there's not physical space in our A&Es to be able to hand over with our ambulance colleagues. And so we've devised strategies to escalate as much as we can within our hospitals. We have a thing called a rapid handover protocol where, in your scenario that you gave there, Councillor Boston, if an ambulance service colleague said, I need to go immediately to that patient because it's life-threatening, they can escalate, and we will essentially move a patient through into a non-A&E space and staff up essentially another bit of our hospital temporarily to be able to release them. Clearly, you can only do that so many times before you run out of space even then. Two big things that are very different for us now, which is different to the last 10 years. We're building a new A&E at Boston, a more than £30 million development there, the largest probably development at Boston perhaps since it was built. Physically, it will be able to take a much larger number of patients, but also it will be designed in a much smarter way in order to help our ambulance colleagues rapidly hand over to the right person first time. We will still struggle, though, if we still have hospitals that are over capacity. But that will make a sizable change. Likewise, at Lincoln, we're doing the same. It's not quite the same size, but again, a substantial increase in the size of our A&E, particularly in our resus areas. And you'll see the frameworks of various things now as the building site that's progressing well at both those sites. That will be something very different, certainly, to anything we've had over the last 10 years. We are focusing on systems outside of our acutes to be able to transfer patients into a more appropriate environment that don't need acute care, don't need to be in hospital, but obviously we need services with enough capacity to be able to take patients out of the hospital in place first, and we're doing that collectively across the system, not just ULHT, but LCHS and local authority colleagues all working on that scheme. And then in terms of the paediatric unit, so the paediatric unit we're very proud of at Boston. Certainly throughout COVID it has worked extremely well and has delivered really, really very positive outcomes to our patients and continues to support children coming into Boston Hospital. Clearly we've got a process whereby If those patients are going to stay for longer and require a higher level of care, they move to Lincoln. But ultimately, we do provide, and we still have a paediatric unit there. It's just in a format that means for some patients they will transfer to Lincoln. In a similar vein is that some patients will also transfer to Nottingham as the comprehensive children's centre for East Midlands as well, sometimes to Leicester if it's a cardiac condition where they need specialists that we can't offer. So we're very proud of the work that they've done, and actually the paediatricians are going to help bolster that for us, not just at Lincoln but at Boston as well going forward. So I hope that answers your questions.
Thank you. If I may come back
Briefly, Councillor Boston.
Briefly.
Thank you.
Well, as regards the Boston paediatric unit, I think the only persons in this room that were present when it was first put to us is perhaps Dr. Wookie and the chairman. We were told that it was a temporary measure and it wasn't really good enough that we were transferring patients that needed longer care. They should be able to stay there nearer the parents. We were told that it's a temporary measure. Are you now telling me it's a permanent measure and we're going to do nothing about it? And the second thing is, I'm afraid, and please don't take this as a personal insult or anything, I'm afraid that what you're telling me about the ambulance delays and what is happening is almost word for word what was being said 10 years ago, and nothing has changed. We need to see some action taken on that. And I accept, I don't know if the hospital systems accept, that these are holistic issues. Yeah. It isn't just the ambulance, it isn't just A&E, it's holistic throughout the hospitals and the NHS service, but it's not acceptable to have somebody in the situation that I explained. Thank you, Chairman.
If I could just come back, I'm not saying it's a permanent measure at all in paediatrics, so apologies if it's come across as that way. I'm saying very proud of the unit that's done an excellent job during that time. The consultants will absolutely go into the service in terms of the temporary measures, and the configuration of that is still subject to what we described before. I'm afraid I'm going to have to defer to my colleagues because obviously I wasn't here to present on paediatrics today. Happy to add more outside or indeed to a further meeting if you want additional information on that. And I wasn't here 10 years ago, so I can't comment on that. But as far as my records go back, I can't see us ever investing in our A&Es in a way that we are currently doing in the history of ULHT. So I do believe that is something very different.
Thank you. Okay, Councillor Smith.
Thank you, Chairman. Excuse me. There's a couple of points. Firstly, in terms of robotic surgery, how much is there patient choice in that? I.e., can a patient elect to say, I am quite prepared to wait to have a human do it because it's a very emotive issue. It's would you get into a plane that's piloted by a robot, or would you get onto a train that has no driver? Secondly, Sam, the point you made about funding actually to me is quite concerning because it's very chicken and egg. It's, well, if you're improving, we'll give you more money. Well, maybe you will, and I use ULHT as an example. This is a pure example that isn't necessarily the case. Maybe ULHT needs more money to improve, but we're not going to get more money because we can't improve and we haven't improved. So that to me is a concern. In terms of video consultation, in what way is that being used? Because yes, I appreciate it reduces the time it takes for clinicians, but I'll use my personal example. I have cerebral palsy and I'm under a specialist in Nottingham, and during COVID they did telephone consultation, which, to be blunt, isn't much use because you can't see my legs through a telephone. So I just urge caution on how that's used, and actually some patients, I could use video conferencing, but I have elected by choice to travel to Nottingham because I prefer to actually see my consultant, to see me, so they can properly look at it, and I can see what they're doing, they can see me, we can have a proper conversation. So how much of that is patient choice? On the issue, or on the point that was made about associate registered nursing, is there not a concern, or is there not a risk of a viewpoint that is a, shall I say, de-skilling, for want of a term? And I'll use the example of ultrasounds, because years gone by, you had to be a radiographer to conduct an ultrasound, to then look at it, to then go further on. Now you don't. Now you can have an assistant radiographer do so much of it, then the radiographer does another bit. That is an issue of to me is an issue of de-skilling, because actually we can't recruit enough radiographers to do what they used to do, so we've had to merge and meld so it sort of works. And the last point is, as the chairman sort of looked at me and I looked at him, I wouldn't count, shall I say, on GP interaction with patients to get your information. If you do, you're going to have egg on your faces. And I'll use myself here, my specialist knows more about me and hasn't seen me in 10 years than my GP ever has about my condition, and it took 6 appointments in Lincolnshire to be told, oh, we have no lower limb specialist, which I already knew, so that's wasted your LHT time, it's wasted my time. And actually there's an issue of, if a patient says, I want to travel to Nottingham because that's where I know the specialist is, it should be ULHT. Okay, the patient wants to do that. We know the specialisation's there. If the patient wants to do that and we're not expected to stop up the cost, let the patient do that. You're saving yourselves time, the patient time and money. Thank you, Chairman.
So I wonder, the first question on robotics, I have a resident expert behind me, so if I could pass to Mr. Simpson.
Thank you, Simon. I'm grateful for the characterisation as a robot expert. I will do my best to justify that. I would stress that we regard robotics as hugely helpful ancillary aid to surgery. This is not relying on the robot to function independently, clearly, and it's an evolution of existing laparoscopic surgical skills that allow for much finer movements, particularly in areas of the body such as in the pelvis that are very difficult to access using conventional techniques. Clearly, there's always a patient choice in terms of the choice of surgical technique, but in my opinion, the majority of patients elect, and have for many years elected, for robotic surgery, and it's a real development. We can now offer this locally. In terms of the comments on virtual consultations, I do acknowledge that as a clinician, and it's exceedingly frustrating not to be able to see and examine people, and that was a real barrier to effective care during COVID. However, we do find a cohort of patients who, having travelled 20, 30 miles for a brief consultation to tell them a blood test result, that telephone consultations do have a real place and will continue to do so.
Thank you. If I answer the money and then perhaps hand off to Karen, if that's okay. The money around improvement, I perhaps interchanged the words too much. Improving the waiting list is delivered through delivering more capacity, so a better access, more outpatients, more treatments and things like that. And that's essentially how the money comes. So you do have to do more. You can't just improve. So that then does encourage us, and it also covers, to deliver more, sometimes we have to pay more people, we have to spend more money on equipment and various things like that. So the money follows in quite a sensible way in that guise. There are streams of money that are purely around improvement, which work in the other way. So if you have a sizable challenge and you're not able to deliver what's being asked of you, there are other transformation pots which are to be spent in different ways, which we may not get access to in Lincolnshire because we've had to deliver. And indeed, one of the first of those, called our Transformation Fund, we didn't get access to in Lincolnshire because we were doing so well. But this other stream of money came to pay for the extra capacity. So hopefully that answers your question there. And then in terms of associates.
So I'll pick up your question, Councillor, about the potential de-skilling of individuals, and I could see how you would think that, but it's not actually borne out through the professional routes. So we know that there are a number of things that impact on this. One, there isn't the workforce, so there aren't the professionals in what I would describe as the traditional way that you might expect. For example, a radiographer to undertake a procedure and then may or may not be able to interpret, aren't there, using your example. So what we are doing is upskilling others to support that, and therefore the person who is the professional is also further upskilled to pick up other technologies, other advances in medicine, other advances in treatment and care. So what you actually see is an upskilling up through all of the professionals. So it's not actually borne out that you do see, certainly I don't think any of the Royal Colleges or from my perspective that we've seen any de-skilling. What we've actually seen is increases and enhancements of practice. Thank you.
Thank you, Chairman. I only raise this because through my time as a district councillor and now as a county councillor, I've been very fortunate to have a couple who are people who are ex-professionals in various fields, and their concerns are very real that this is a de-skilling. So how would you address their concerns? And this is not me as a layman. These are former nurses. These are people who have been one gentleman who is a very good friend of mine was very highly qualified in Her Majesty's Armed Forces in mental health during the first Gulf, and then went into the NHS on the mental health side. So how would you allay these fears that actually they as professionals come to me and say, actually, they say this to you, Tom, but that's not the case. This is actually what happened. How would you allay those concerns?
Thank you, Councillor. So we have a very robust skills framework that we align roles to, and that enables us then to be really clear about the competencies and the skill set that are required for those roles. So in using that, we apply it to any role, and we're creating new roles. So rather than trying to box and cox roles into existing professional groupings, we're starting to think differently about actually these are the specific competencies and skills that are required in this particular area. What role can we then develop in conjunction actually with the university, because we want to get the research skills in, the development skills, etc. And we create a role. Nursing associates is the most recent example of that across the NHS. Which deliver an enhanced level of care, which supports the registered nursing workforce. It just so happens that there's a sizable gap in the registered nursing workforce. So I hope that helps, Councillor. Thank you.
Thank you. Councillor Chalmers.
Thank you. So actually, I've got a few questions, I suppose, and they all came from an initial conversation that I had with one of my constituents who was denied care in the first instance during COVID, and then again after the pandemic. It seems to have lapsed because he doesn't have a phone and wasn't allowed to walk in off the street to a GP surgery to make an appointment, which is appalling. Which then led to a conversation by that GP surgery where I was invited in for the day, and they went through every single problem that they have. So I've actually got a few, but one of them you've touched on today, which is recruitment of GPs. Now, you measure your recruitment, I saw it in numbers, and that we have been able to recruit doctors across the surgeries. The GPs are reporting back that actually...
Councillor Chalmers, this isn't a report on GP surgeries.
No,
we need to hone in more on United Lincolnshire Hospitals Trust, please.
Yeah. So actually, and this was where I was going with this, I wanted to give some backstory. Are we measuring the recruitment of GPs correctly? Because the head of the surgery said that new GPs are only really interested in part-time. They won't work before 9 a.m. or after 5 p.m. and they're not interested in call-outs. So if we're looking as a target for the amount of recruitment overall, how has that had an impact on the hours that are now being worked by the NHS? So that is the question. As I say, there was just some backstory, and please, this is my first time.
Of course. Thank you, and thank you for contributing. It's which is obviously our colleagues here will only be able to speak from the hospital trust side of things realistically. Karen.
Thank you, Councillor Macy. Thank you, Councillor Chalmers. Sorry, I can't see the sign. So, as Councillor Macy says, I can't offer any view on the GP practices. The CCG would be able to do that on the behalf of the GPs, but just transferring the principle of that question into the acute setting, we look at both the whole-time equivalent of individuals and the number of actual individuals, because of course you could have a job share, you could have annualised hours, so we will look at hours, whole-time equivalent, and then the budgetary impact of those and the specific budget, are we in plan with the budget or over established? And that's where the conversations about temporary workforce come from in terms of agency usage and spend, bank usage and spend. So all of those metrics are what we analyse on a weekly basis through our executive team for the whole of the organisation, and then through one of the subcommittees of the board, which is our People and OD committee, which specifically focuses on workforce. Thank you.
Thank you. And if I may, we did have an update from GPs at our last month's one, so we will have another one. I think it's in about October, Simon, is that right? So we can sort of get more into the nitty-gritty of the local sort of element there. So, and any other questions, if you do have, Simon or I can pick them up directly with our clinical commissioning group on your behalf. Thank you. Okay, I've got Dr. Wookie next.
Thank you, Chairman. Brian Wookie, Healthwatch Lincolnshire. I had a number of questions. You'll be relieved to know that some of them have already been addressed, so that may speed things up a little bit. The first one was relating to diagnostics and the plan or the aspiration to increase to 120% over present numbers. And we've already talked about workforce problems, and I just wonder how you're going to do that. And you may say, quite rightly, that you think that the community diagnostic centres will be a key element in this. And so, although we have touched on this before, but this is actually current in the sense that the one in Grantham is open and running after what I would describe as fairly sketchy consultation, without a lot of knowledge of exactly how it was going to run. And the second one, and the options for the second one, are currently out for consultation, and the public is being asked to make decisions about it. And Healthwatch ourselves are talking about this next week. What isn't made clear in the consultation is what the clinical pathways are to and from these diagnostic centres. Are they in fact a direct access arrangement whereby they will take referrals from GPs in primary care and from secondary care within the hospital, and that would then be a decision about the ease of access as to who was going to deal with them. If it's not going to be open access from primary care, then you are reducing the effectiveness immediately, because it means that those people would still have to go to an outpatient clinic in order to get referred. So I hope we can have some clarity about that, because it isn't very clear in what is described at the moment. So that's the first thing, and I think it's happening now. And although we may be discussing it, Chairman, in a month or two, some of the decisions will have already been made by then. And the second one, which relates actually to what Councillor Boston was saying, and I won't repeat his concerns, which I share, about ambulance waits, and I know it probably is 9 years since the, but clearly that has been, very, very much affected by COVID, and I think we have to accept that there's a long way back, and it's not going to get back straight away. But what's not been mentioned, or only very briefly, is the fact that part of the problem is, as you said, you had 55 patients in the emergency department looking for somewhere for them to be moved within the hospital. And that goes right on forward to discharge and discharge into social care. And every lower grade that we take into the health service is probably somebody who would otherwise have gone into social care. So hopefully the future arrangements may help to streamline that. But we did a survey, Healthwatch, about 4 or 5 years ago on ambulance waits and discharge, and I don't think anything has changed as far as the discharge end of the system since that time. And that is a major issue, and I'm surprised it hasn't actually been raised in your presentation. So those were the real ones. The other thing about the ambulance is that it is one of the two must-do issues raised by the CQC. And again, I'm a bit surprised that it wasn't raised at the beginning, because that's something you've really got to do somewhere or other, or explain, you know, why you can't do it.
Thank you for that. I'll perhaps pick some off and go to Sarah, my colleague, for some more of the detail. So in terms of the overall diagnostic capacity, I think was your first question. It's one that we are really quite confident, probably one of the areas we're most confident of. And in fact, in terms of our recovery coming out of COVID, we did at one point get to 140%. And in some areas, such as endoscopy and diagnostic imaging and CT, we got to nearly 200% in terms of the delivery. And it's not compared to now, it's compared to pre-COVID levels. So it was a sizable. Now, sustaining that is the real challenge for us. And as you say, workforce is a key part of that. But also the equipment and the materials. And it's why so unfortunately we've had the fire at Lincoln as that set us back there, but that's where the CDCs will absolutely help us with that, and I'll go to Sarah in a second. In terms of the clinical pathways for CDCs, which I think was your question there, I don't think they're completely locked down at this stage. I think there's the obvious use from primary care is direct access, which there is a substantial demand for. Has been during COVID, which hasn't necessarily been met, and we're looking to make sure that's back in. But also there is follow-up diagnostics, which is some elements of the chronic, some elements of cardiac examples, where actually patients don't require to go into the hospital. Actually having their test in a CDC will be a much better thing for it, and they can manage their care much more effectively in that way than necessarily having to queue in to get into the acutes all the time. But in terms of our recovery position at the moment for diagnostics, Sarah can perhaps bring us up on that.
Yeah, it was just to kind of repeat what Simon said around, actually we're already delivering the 120% because it's based on pre-COVID levels, and we're only looking to increase that. We know that there's going to be additional demand from clearing the waiting list patients that will require that. But I also just wanted to add something to the CDC bit, the question that you raised. I know we're coming back next month to do a more detailed presentation on it. At the moment, we are, it's purely ULHT activity that's being delivered out of the Community Diagnostic Centre. So where GPs are already requesting direct access, we can provide that through the CDC. Nationally, the ambition is that we have community diagnostic centres that are digitally enabled so that you can get referrals from not just your local acute trust, but your independent sector providers, from patients outside of county. But we don't have that digital infrastructure yet, so that's part of what we need to build to enable our CDCs to be able to receive all of those referrals from those different places. You need a patient administration system where you can get all the referrals into so that people don't get lost between one provider and who's actually then delivering the test, and to be able to then get it back to the GP practice. But so the way that we're operating at the moment is the same as if we didn't have CDCs in terms of referral pathways. GP can refer into ULHT for a direct access diagnostic. We're just delivering it out of a CDC in a separate place. And we're able to do that because we've had the national investment around putting workforce into that. So that's how we're able to increase that capacity.
Just on your final point, in terms of ambulance handovers, obviously the presentation today was around elective recovery, so I didn't go into urgent care in much detail, other than obviously the risks, and happy to answer questions, but obviously we didn't present the full perspective of urgent care. It is in the CQC report, absolutely, and actually much of what's described in the CQC must-dos around how we manage the safety of patients waiting on ambulances and in our hospitals we have achieved, and actually we've shared best practice of how we manage the situation running ambulances on our sites and waiting for access with other systems who have struggled. What that doesn't do is solve the root cause of the problem, which we've touched on earlier in an earlier question, which is an overcapacity emergency system. And your point there, Dr. Walkie, around delayed transfers into care outside the hospital is absolutely fundamental to us as solving that.
Very quickly, to come back, I mean, this meeting, one of the objects of this meeting was the response to the Care Quality Commission inspection, which I think covers what we're supposed to be talking about. And I don't underestimate the problems. If it was an easy problem, it would have been solved years ago. But the fact remains that unless you can start shifting people, that sounds rather arrogant, but with care and precision and courtesy out of hospital into the community in some form or another, we're never going to solve this problem. It's going to tail back to the ambulance service forever, really.
If I might just come in and just add a final point, Dr. Wookie, thank you. Of course, as a system through the integrated care system and the shadow integrated care board, which will become itself from July, there's a huge amount of work on a system delivery plan specifically around dealing with the urgent and emergency care demand and then all of the discharge work. So overview and scrutiny panel may want to look at the integrated care board in terms of course, we have a significant part to play in that, offering you some more of that detail. Thank you.
Thank you. Got Councillor White next, please.
Yes, thank you. Sarah, you've answered part of my question. I was going to ask about access to diagnostic centres, whether for residents and whether the access is restricted to a certain area, because there have been people on the radio, professors, speaking about patients self-referring themselves to diagnostic centres. Is that part of what you envisage in the future?
Certainly at the moment, we're still working on actually you have to go to your GP to get referred. We need to be able to manage the demand and make sure that we've got the right kind of clinical pathways through into those so that we can ensure that we're using our capacity in the right way. We've got, as you've seen, we've got a lot of people on the waiting list that we need to make sure we've got capacity for to be able to see through those diagnostic centres. So at the moment, we're still working on actually, you need to go to your GP to be able to be referred for a diagnostic. But in future, we can start to look at alternatives to that where we know that we can deliver it.
So is it restricted to a certain area, the Grantham one?
I forgot about that bit. So no, it's not. It's delivering services to the local area, but anybody can choose to go there if they would like to. We've got, we're doing a lot more around being able to choose where you go throughout the county, because we recognise that some areas people find it easier to get to, and part of our second CDC as well will be about looking at the harder to access from a geography perspective. But at the moment, no, anybody can choose to go there if they would like to.
Thank you.
Thank you. Councillor Cleaver.
Thank you. I noticed that in your list of priorities, it says one of your priorities is introducing care home remote clinical observation kits. I'd love to know what the scope of those kits is, what exactly they can do. But also, again, as integration has just been mentioned, how does that dovetail in with the services that the primary care networks provide into care homes, which is obviously something which we're trying to expand at the moment, as far as I understand it. Thank you.
Yes, so we're probably moving into an area that's not my specialist area, but in terms of the digital innovation, I think what we're trying to talk about there is using some of the lessons that we've learned during COVID on better use of digital services to where people really don't need to come into hospital. They can be cared for at home or in a home in a better way. In terms of the scope, actually some of the innovation out there is huge, actually, even with remote camera systems and various other elements, bed monitors, floor monitors, a combination of blood pressure and various other things. More likely is actually the widespread use will be a relatively limited use of that technology, but a limited scope, but a broadened area in terms of the number of places it will be delivered. From an acute hospital perspective, we'll do little of that. The majority of that will be led by our community partners, and that will absolutely incorporate the PCNs and our primary and community networks that will manage that. We do have virtual wards now, which one of which is our virtual frailty ward, and that might provide step-up care if some of that technology suggested a patient needed more specialist intervention. That will be delivered still in their home, remotely with one of my colleagues, a geriatrician or a specialist, giving the appropriate advice. And so that's kind of how we envisage that developing over time.
Thank you for that. I would be interested to know more about how integrated care is going to work in that scenario, particularly with the care homes. Thank you.
Thank you, Councillor Cleaver, and it's something I'm sure we'll be looking at a later date anyway, so thank you. I have Councillor Loughagan left, and then I'm going to close down the debate other than a couple of questions I have. Councillor Loughagan.
Thank you, and thank you for allowing me to ask a question. This is my first time at this committee, so forgive me. But having listened and read a lot about the diagnostic centres and listened carefully to what people have said, I'm still not clear as to what they are intended currently to achieve. I mean, Dr. Wookie was asking the pathway to the diagnostic centres. Will it come from primary care or will it come from the hospital? And I haven't understood a clear answer to that, or what the intention was, whether it was intended to address waiting lists and therefore it's UHLT, or whether GPs will be able to refer directly into the diagnostic centres when somebody comes to them with for the first time with a symptom that they're concerned about. So I'm just not clear as to what the purpose is. And I understand there's one already operating and one under consultation. I'd just be grateful for an answer. Thank you.
So the types of diagnostics that are being developed in the CDCs are growing over time. The types of diagnostics that we have in place now are around diagnostic imaging and cardiac physiology, so echo and ECG, EKG type diagnostics. As Sarah's described, in order to get that diagnostic, you must have seen a professional first. What we have is two routes essentially into that. The first one is via your primary care practitioner or by a GP who will say, actually, I think you need a ultrasound or an echo or whatever that might be. And there are many patients already on that waiting list who would then access the CDC services. There are also some patients who are within the hospital system who may need a 6-monthly or 12-monthly cycle of having a repeat test to see if anything's changed in their care. And again, that's another group of patients who could access the CDC. Much more convenient for people, particularly if they're going to one down the road or in their locality, than having to come into the acute hospital. Over time, it will develop, so we will be able to introduce additional types of diagnostics, including endoscopy. And again, that will give us more opportunities to open up more access routes in. But currently, the way that this is designed and the access that we've got is we have a number of patients already waiting, either from a referral from a GP or from a primary care practitioner, or by waiting in the acute waiting lists ourselves. So they will be the main routes in. Again, we'll be able to talk about it more next time, but hopefully that answers your question.
Thank you.
Okay, thank you. I've just got a couple of questions myself. So I think you've alluded to this in part. However, on page 34, bullet point 2, is the Trust on track to reduce the long waits of 104 weeks by June?
Yes.
Thank you. And then looking at the Bragg ratings, beginning on page 47, a large number of these are either due for completion or should have completed now. Have you achieved those listed with a deadline, and how likely are you to achieve the other dates that were within there?
So those that had a deadline that's currently passed as of today, we've met. The others were on track to, with the exception of some in relation to the time. So we're taking the actions, but we're likely to slip the time scale on some of them that aren't related to direct patient care. And the root cause of that, one, was the fire, and two, we called a critical incident as well due to the pressures in the trust, which have had an impact on some of those lower risk actions. Thank you.
Okay, thank you. And my final question is, how often is the ULHT board going to monitor the CQC action plan?
So each of the board subcommittees monthly receive their respective element or cut of that improvement plan every month, and the board will oversee it quarterly.
Okay, thank you. In which case, I'm going to move to a proposal that the information presented on the Lincolnshire Elective Recovery Plan and the CQC Action Plan from United Linkages Hospitals Trust be noted, and that a further update be received on the progress on the CQC Action Plan in 6 months' time. And I also wanted to thank you for a very thorough and robust document. It's much appreciated, and thank you for your presentation. Do I have a seconder to my proposal, please? Thank you, Councillor Smith. All those in favour, please show. Thank you. That's supported. I think unanimously, thank you. In which case, we'll move on to agenda item 6, United Lincolnshire Hospitals Urology Update. This item was circulated as part of the agenda packs on pages 147 to 176, and I'd like to welcome our presenters, Mr. Andrew Simpson, Consultant Urologist for United Lincolnshire Hospital Trust, and Simon Evans once again to make the presentation. Again, I'll give you about 10-15 minutes to run through it, and we'll take questions at the end. Thank you.
Thank you, Chair. So the committee will be aware that a presentation was provided on the 16th of February in relation to the newly reconfigured urology service at United Lincolnshire Hospitals, and this paper provides an update to that as requested by the committee at that time. I won't go through the paper that you've received in detail, but just to draw out the key elements. Briefly, the background was a urology service that was struggling with instability in the on-call service, repeated cancellations of elective activity, significant recruitment difficulties across grades, and failure to meet standards, particularly in relation to acute management of stone disease. As a result of reviews by the Royal College of Surgeons and the Get It Right First Time, or GIRFT team, there were strong recommendations for a hot week model for senior medical staff, a centralisation of acute activity, and expansion of our elective hub at Grantham. The model was developed with considerable support from the GIRFT team and implemented in August of last year, since which time it's become fully embedded, yielding a balance of services across the sites with a focus of acute urology at the Lincoln site. This has been supplemented by recruitment of a new tier of acute care practitioners in urology, led by a nurse consultant who act as the first point of contact county-wide for acute urology. We're now fully recruited at all tiers, including at consultant level. Indeed, the recruitment of consultants skilled in robotic surgery and the procurement of a state-of-the-art surgical robot, as you've heard about, has permitted the repatriation of complex urology cancer work from our sister trust at Leicester, allowing Lincolnshire people to receive treatment in county and avoiding the substantial inconvenience and significant delays in treatment heretofore experienced. The monitoring of the performance of the new model continues through a comprehensive performance dashboard, and key figures of this have been included in your papers. To draw out the main themes from this, there's been a significant and sustained fall in the number of emergency admissions, despite an overall increase in emergency care demand. And this reflects an increased ability to see and treat urology cases on a same-day basis, which reflects the enhanced level of staffing devoted to acute urology. With the lower complexity cases treated on the same-day basis, the length of stay for admitted emergency patient has unsurprisingly increased. Elective activity shows a balance across the three main sites, with Pilgrim delivering a range of core and specialist stone activity, Lincoln delivering more complex surgery, including robotics, and Grantham delivering the higher volume, lower complexity work, which, as we've heard, will be an increasing focus during the remainder of this year, driven by the elective recovery team led by Professor Briggs. Cancellations on the day for urology have been virtually eliminated, despite very substantial emergency care pressures. Readmissions for urology have fallen significantly, and in part this relates to definitive treatment for emergency patients being undertaken on the same admission on the hot operating lists. Although our elective performance in terms of referral to treatment targets, along with many specialties, remains a challenge, we've cleared the backlog of our longest waiters, and we now have no patients in the specialty waiting over 65 weeks. We have struggled to meet the cancer 28-day faster diagnostic standard, although with our new acute care practitioners now expanding their role to include diagnostic activity incorporating flexible cystoscopies and prostate biopsies, there will be a step change in activity in these key areas for diagnostics. We're of course conscious of the potential impacts on patients presenting to sites other than Lincoln with acute urology conditions, and we continue to support staff in the emergency departments to provide immediate care locally through education and remote advice and the provision of duty urologist sessions on a daily basis at Pilgrim to provide in-reach into the emergency department and other acute areas. Nonetheless, on average, between 1 and 2 patients daily will require transfer to Lincoln for further treatment. Reviewing our adverse incident reports since reconfiguration, we've only yielded 2 incidents relating to delays in transfers for assessment, and there have been no patient complaints or pulse concerns relating to transfers. The patient satisfaction remains high for urology, scoring consistently above the trust average on the friends and family tests. The staff concerns have focused on the provision of urology advice and support to the Pilgrim and Grantham sites. However, there is consultant presence on both sites on weekdays, and the Pilgrim site duty urologist provides on-site support and advice to inpatient services on a daily basis, and the Grantham ward patients are supported by core trainee grade doctors with support from the duty team. Concern does remain in relation to the availability of unplanned urology support during operations undertaken by other specialties. However, the expansion of the on-call team does allow surgeons to travel to support other sites as required. Financially, agency spend has been eliminated, and the cost improvements envisaged as a result of the reconfiguration have been somewhat modulated by extra duty payments to support additional diagnostic and operating activity as part of elective recovery. In terms of the outstanding actions for the project, the planned Urology and Trauma Assessment Hub is yet to be implemented, contingent on identification of appropriate funding and staffing. This does remain a priority for the service, which will also reduce pressures on the emergency departments and facilitate transfer of urology patients from other parts of the county. In summary, since our previous update to this committee, the reconfigured urology model has become accepted and embedded, and the service delivers effective and responsive care despite substantial pressures on the trust services. Of note is the advent of robotic surgery, which has already delivered major urology cancer surgery locally for over 40 Lincolnshire patients since mid-February. And I would ask the committee to accept this report.
Thank you. I'll open to questions. Have we got any questions from the committee, please? Councillor Boston.
Thank you, Mr. Chairman. It isn't really a question, it's more a comment. Being a man of a certain age, I have a lot of friends who have had to make use of the urology department, and also being of a certain age, I also know several females that have had the stone problem, and I have to say the feedback that has come to me in respect of the way that they've been treated, the speed of treatment, the effectiveness of the treatment, and the confidence in the end result has been amongst the best that I've heard of any of the NHS services. So I congratulate you and I say thank you very much on behalf of my constituents.
I'm most grateful, Councillor Boston, and will assure that the team receive those comments.
Dr. Wookie.
Thank you, Chairman. Actually, my introduction was going to be more or less the same as Councillor Boston's, but Health Watch have had no complaints or issues raised with the new system, so overall, I think we all wish you well, and I think there's been a significant improvement over what occurred before. I have just one question, and that is a similar question that arose, I think, when you first came to this committee, and that was the situation of patients who turn up in the emergency department at Pilgrim and turn out to have a fairly significant problem. And at that time, it seemed as though what was being said, if they'd got a very acute problem, there would be somebody on site to see them. But if it wasn't quite as acute as that, then transport would be arranged to Lincoln. And that didn't quite seem to be logical. And if I can give you an example, and this isn't a real example, but somebody, say, in Swineshead, which is near Boston, developed something seriously wrong. Either they were bleeding or they had renal colic or something like that. And they decided to ring the ambulance, or their family rang the ambulance, then that patient would have been transported direct to Lincoln. But if they took it upon themselves or their family to be taken to the emergency department at Pilgrim, then they would only go on if they weren't too bad, rather than the fact you'd think that they would go on to Lincoln if they were more acute. And I just don't quite work out the logic of what's happening for those sort of patients. And you will get people who don't follow the pathways inevitably. And so if you could explain that. I think you did mention actually in your last document there was one instance of a problem like that. And that, at the time when you came before, seemed to me and to Health Watch to be the only weakness in the system. So if you could just clarify, that would be really useful.
Yes, thank you for that. I think to explain, really one would consider three levels of patients who might present themselves to the emergency department at Pilgrim, let's say. Clearly one would hope that the pathways would direct them elsewhere, but clearly people will present still to Pilgrim. At the first level, there are people who require some relatively minor intervention, such as a change of a catheter or a flush of a tube, which now, with the education we put in place to the emergency departments, can be achieved locally without the need for transfer. So that's the first tier, if you like, of presentation. The second tier are people with more significant problems, such as an obstructing stone in the tube draining the kidney. Imaging would be performed at Boston, so we have a diagnosis, rather than an undifferentiated patient with abdominal pain, which could be anything. But such patients will be transferred as expeditiously as possible to Lincoln. The third group of patients relate to patients who are critically unwell, in whom, for example, with significant sepsis due to a urological cause, we're struggling to maintain the blood pressure, in which case we would invoke the support of our critical care team and then arrange for attendance at the Boston site by the responsible on-call consultant or senior urologist. Does that clarify?
Can I come back? Yeah, I think so. I mean, in the last case you mentioned, do they eventually transfer to the acute unit at Lincoln, or do they stay in Boston?
So clearly, if there was someone who was critically unwell, that may involve admission to the critical care facility at Boston and then intervention at Boston by the urologist, because it would be unreasonable to transfer unstable, critically unwell people in an ambulance with a lesser degree of support.
Thank you.
Thank you. Councillor White?
Yes, thank you. This is something really I don't think you've got any control over, but with reference to what my colleague, Councillor Boston, said, I think is he referring to the prostate. There's no screening for prostate cancer, and as a resident in my community, I know how delays in referral have impacted on patients. So, and I'd like to say that quite often you have to ask the GP yourself if you want any kind of test. There are no tests offered to you. And yet you read on charities such as Prostate Cancer Charity that people over 50 should have some kind of discussion about whether they've got symptoms, etc. I just wondered what your opinion on that is.
I think it's very clear that men's health, particularly in relation to the prostate, is a priority, looking at our performance for prostate cancer survival across Europe. We perform relatively poorly. And this does relate to identifying the disease at an early stage, which does rely on taking symptoms or blood tests, which are often performed routinely as part of a general health screening program, seriously. In secondary care, we do our very best to ensure that all referrals are assessed quickly, and in fact we use MRI scanning probably more than any other unit in the East Midlands as an early detector for prostate cancer. But it's, I agree, a programme of ongoing education to ensure that our colleagues in the community think about it and engage patients in terms of identifying the possibility of prostate cancer as a diagnosis.
Thank you.
Thank you. Councillor Boston, I'll allow you to come back in.
Yeah, it's specifically on that subject. You will be aware that I raised this subject maybe 3 years ago here. I had a system potentially in place to screen significant numbers of men off the NHS premises to do the initial internal test and the PSA test. The sticking point was finding somebody who would put me in touch with who could supply me with the kit for the blood tests and where the blood tests could be analysed and resulted. I had 2 doctors who were willing to come out and do the work. I had premises identified. ULHT and the CCG that I'm part of turned around and said there is no screening system plan in place anywhere in the UK, and we will not support you. I was absolutely gobsmacked by that, and I would appeal again if you and your colleagues can come up with somewhere that can provide me with the... We were prepared to buy the syringes and the equipment for taking the blood tests. It wasn't a matter of asking for it free of charge. We were prepared to buy it. We were providing the initial medical care. Cancer UK said, we're not interested in anything about supporting people to do the initial diagnostic tests. We only deal with it once it's been diagnosed and being treated. Now, I think that's disgraceful. If Nottinghamshire, if Derbyshire, if Staffordshire can support the sort of system that I'm asking for, the transport was all organised through blood bikes in those areas, why won't Lincolnshire support us?
Thank you. And I recognise that clearly we do many blood tests for prostate conditions, PSAs, and many patients come to us through a variety of means, having been screened effectively, but in a sort of non-coherent way. I think the service would welcome a more coherent structure for that. I'm happy to engage in discussions regarding that.
Perhaps we could speak afterwards and get some details from who can speak.
Of course.
Thank you. I've got no other speakers indicated. I've just got one question, if I may, and forgive me for being cynical because I think the system seems to be working incredibly well. However, on pages 161, there are two issues that are highlighted as low risks currently, and another issue is rated as moderate risks. We've seen issues with recruitment and retention, which has led to a centralisation of the emergency part of this service. So with those risks and that in mind, what impact would happen if those risks did intensify, and then what effect would that have on the service? Will we be looking at then shipping it out of Lincolnshire?
I don't foresee having to ship the service out of Lincolnshire, and we've talked about the features in Lincolnshire, including the advent of the medical school and the surgical robot, that make this an attractive place to work now in the urology service. And we've seen good levels of application for our vacancies, which is subject to a rolling programme. So I think the retention and recruitment remains a low risk. Clearly, we're utilising other professionals, including our acute care practitioners and our nurse consultant, to deliver many traditionally medical roles. And again, we see very high levels of application for the vacancies in the ACP tier. The risk described in terms of service compliance relates to education, and we've reflected on the ability now for the emergency departments to identify and manage the lower impact presentations. I don't see a reason that would change, provided that education continues. I do have some anxieties about the assessment areas, because that's my one concern in relation to the reconfiguration. And the small number of complaints we've received relate to delays, not so much in transfer to Lincoln, but then finding a location for patients to arrive, and then waiting in A&E for a number of extra hours, which is clearly in nobody's interest. So having a dedicated reception assessment area remains, the absence of that remains a significant risk to the service. But that's raised at our capital resource group regularly.
Okay, thank you. In which case, I've got no further speakers. I'll move to the proposal, and that is that we note the improvements and virtual elimination of same-day cancellations. I don't plan on taking any further updates as it stands unless there's some major alterations, and in which case I'll bring it back to committee. Do I have a seconder to my proposal, please? Councillor Lundworton, thank you. All those in favour, please show. Thank you, that's supported, and thank you very much for presenting today.
Thank you very much.
In which case we'll move straight on to agenda item 7, the work programme. Simon.
Thank you. Thank you, Chairman. If I could ask people to look at page 180, I'll just deal with the 3 working groups before we look at the committee's activity. The pharmaceutical needs assessment, as set out on the papers, is due to meet this coming Monday. The quality accounts working group held its meeting last week, and statements have been prepared on the East Midlands Ambulance Service and the North West Anglia Foundation Trust. And in fact, that one was submitted to the Trust yesterday. The next meeting is on the 7th of June, which will pick up the final quality account for this year on United Lincolnshire Hospitals. The Suicide and Mental Health Working Group, an email was sent to members of the committee asking for suggestions, to members of the working group asking for their suggestions on what details of the suicide prevention strategy and the mental health waiting lists that the working group could look into. So the next stage for me is to start liaising with LPFT and public health colleagues on a date for that one. I'll just move on to the work programme. So just jumping back to page 178, the 15th of June has got 6 items on the list in your papers. Number 5 will not be coming forward because I'm advised that the pre-consultation business case for the Humber Acute programme will definitely won't be ready for June. It may be ready for July, but I think there may be something that they could report. The programme could report for July. So that leaves 4 items. We've already touched on dental services in early discussions and diagnostic centre. But the other 2 items, we are expecting 4 items in all. Number 6 on the list will be just picking up from the working group's recommendation of its response to the consultation. So July, we will be adding in the Humber Acute programme, and number 2 on the list, which is the Lincolnshire People Plan, can pick up some of the themes this morning that in relation to recruitment, which was mentioned earlier. And obviously, on page 180, number 2 is a blank box, but that should actually be the GP services update, which is 6 months on from the last meeting. And if we were going up to November, we would then be adding in the CQC action plan update following on the item earlier this morning. Happy to take questions. Thank you, Chairman.
Thank you. Just want to pick up before I bring in Councillor Whittington and Councillor White. Have you had any feedback yet from the suicide group that we were looking at?
Yes, I have received feedback, so it's
great.
Yeah, I can start to take that forward now.
Thank you. Okay, Councillor Whittington.
Yeah, thanks, Mr. Chairman. One thing that came up in the first presentation this morning seemed to be indicating from the HS colleagues that already we're starting to see the benefit of having the medical school at Lincoln in terms of being able to attract staff and students or whatever. So I'm just wondering if at some point, it may be too early, or it may be that we can put it in the staffing paper at some point, and maybe to be updated in intervals. It would be, what impact is it having in terms of numbers? It may be too early at the moment, but it may be something that we need to sort of have in our minds, because we've sat here, and I've been on health scrutiny now for over six years, I think. And right through that, all through the acute surgery review and all the reviews we've had, the issue of staffing has been a major issue all along. And one of the solutions that was touted has always been the impact of the medical school and the impact that will have upon recruitment and retention. And it seems to be, the indications are that it's starting to have a positive impact. So I'm not quite sure how we would fit that into the work programme, or maybe be badged with something else, but just something that maybe we need to consider going forward. Thanks.
Thank you, Councillor Whittington. In fairness, I think if we could try and build something actually with the university as well to get, from their point of view, because of course, when it was first coming, we did have a presentation about how it was going to work. Then COVID hit, and of course it fell off the radar realistically. So I think if we could bundle something together, that would be very worthwhile taking forwards. So we'll try and bring that on. Thank you, Councillor Whittington. Councillor White.
It must be telepathic, because that's what I was thinking about. When he came for that presentation, he did invite us and said we could go and have a look around the Lincoln Medical School. And I was just thinking whether we might be offered that opportunity.
We can certainly ask. I think, as I say, with the pandemic now sort of abating somewhat, we might be able to go in smaller groups, or, certainly. Simon, I don't know if you want to comment.
Well, yes, the offer was made. The presentation from the medical school was in February 2020, so we all know what happened in March 2020, and that's why the offer wasn't taken forward.
Thank you. Any other comments on the work programme, please? Councillor Lundwatton.
Just one comment, Chairman. Councillor Cleaver did quite a piece of work the other day on the dental services update, and I hope our update isn't just going to get, a presentation from a particular dentist, and I hope there's going to be some research in the background, because we are bereft of dentists for NHS patients. I went to the dentist the other day, and I sat there and I watched a big screen, and I am still an NHS dentist, and there were about 12 dentists in that practice. So, I say to myself, and they were saying all their qualifications and their specialties and all this sort of thing, and I say to myself, well, are they all NHS dentists, or is this a private practice and I'm so lucky that I've still got a brilliant Polish dentist who does NHS work?
Thank you, Councillor Button. As I said, I am actually meeting directly with NHS England to discuss what we'd like to see coming forward. I'm also aware of 2 of the Lincolnshire MPs that are actively pushing to try and have some form of dental school here, and I understand that their plans are looking quite promising, and we may end up with either a course or a school or something similar that could building into Lincolnshire, and that work is looking very, very promising, and we'll be bringing some of that discussion forwards to the next meeting as well, so we'll pick up on that point with them. Okay, any other comments? No, so we're happy with the work programme going forwards. Brilliant, well thank you all very much, and thank you for your attendance today. That brings the meeting to a close.